Everybody have a good Thanksgiving?
Yes.
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 How about you?
It was perfect. I was with family. I ate too much, watched football, took a nap, and repeated.
Yeah, sounds good.
Hello, everybody.
Hi, how are you?
I'm doing well. How about you?
I'm doing pretty well too.
Okay, Cheryl, we have all committee members present that are able to join us today. And I'm ready on my end, so you can take it away when you are.
Okay, thanks, Katie. Welcome, everybody, and thanks for adjusting your schedules to our supplemental meeting that you requested so that we can do a deeper dive into the health expenditures data approach and look at the sources, the potential sources for the first step in the process. So we listened to your feedback about having a majority of the meeting focused on discussion by the committee, and we're structuring the meeting this way today. We've also assigned you some homework if you've checked your DCBS email, and we provided some links for background research on 3 of the 4 approaches. We also invited Janine Smith to come back and review the cost growth data and a couple of other of the sources and approaches that we suggested at the last meeting. And so what I'll ask you to do is if you have questions or you have comments, please raise your hand. I will call on committee members if I haven't heard from you to make sure we hear from the entire committee. So I am first going to insert a reminder that we are basing our finance and revenue recommendations on PEB, Public Employee Benefits Board, I think is what that stands for, benefits as the preliminary structure. And if our Universal Health Plan Board Chair is here, I want to invite her. Is Helen here, Katie, do you know?
Yes, I just have to make her co-host. So just 1 moment. She'll be connecting in just a second.
So while she's becoming co-host, I just wanted to ask Helen, the board chair, to summarize the rationale for beginning with the financial structure of the work. So she's here. I'll throw it to her.
Hi, everyone. Thanks for letting me take a few minutes. And I just want to start by saying thank you to all of you for serving on this committee. This is no small task for sure. So we wanted to have the finance committee lead for a couple of reasons. One reason was the task force that preceded this board already did quite a bit of work on plan design. And what they came up with was that they wanted to structure this plan based on PEB benefits, as Cheryl just referred to. And so the preliminary structure that this board, the Universal Health Plan Governance Board, has agreed on is to adopt the recommendation of the task force and to agree that the plan that we're building is going to be based on PEB benefits, current PEB benefits. And so when you're thinking about what you're covering and what's going to be available to all Oregon residents, it's going to be, as a starting point, the PEB benefits. Now, it is possible and likely that that will change as our work progresses. We may add things to it, we may adjust things, we may expand certain benefits in some ways, but we don't know that yet. And that's what Plan Design Committee is working on. But for your work in the Finance Committee, what we'd like you to focus on is PEB benefits for all residents. I'm guessing you would need to decide on a baseline year in terms of costs for those and figure it out from there. So that's the main reason, is much of the benefit work was already done in task force. But the second reason is when efforts like this, in terms of trying to figure out a universal health plan for a state, have been approached in the past with other states, the problem that they ran into is they spent a great deal of time working on details of the plan design, how hospitals would be paid, or what benefits they wanted to expand or offer to everybody, or what they wanted to cover. And then when they got to the revenue piece to try and pay for it all, the numbers didn't quite work out. The revenue sources and amounts are obviously going to make or break whether this is feasible and acceptable to our state legislature, to the general public, to businesses. And so what we're asking you to do is think through a financing structure for a universal health plan that considers different options for revenue and which ones are most likely to be successful. So for instance, it seems obvious and apparent that one revenue source will be a new income tax on households. What do you think that would look like? We want to hear from this committee what that revenue stream would look like. At what income level, tax bracket would it start? And how would it progress up? Would it be progressive? I assume it would be. That's kind of what the task force thought was most likely. But what are the feasible amounts? Obviously, you can't have it so big that it's untenable for households. So what is a reasonable amount? And if you set the income tax revenue stream at that level, how much would that raise? How close would that get us? In addition to that, would you consider a payroll tax, which is the other recommendation from the task force? And if so, what would that look like? How does a payroll tax affect small businesses and large businesses? At what level would a business qualify to have to pay that payroll tax? Those are the questions that we'd like you to sort out. In addition to those, are there other revenue sources that we haven't considered? Where would additional money to fund the plan come from? So what we're really hoping, more so than a strict dollar amount, is a financing strategy. You'd have an income tax that would account for this portion of the cost. You'd have a payroll tax that would account for this, and then you'd use these other revenue sources to fund it, and those numbers could flex. What we've heard from our consultants is that once we understand what a feasible, reasonable, legal tax structure, revenue structure looks like, we can adjust the benefits to fit that. In fact, that's what insurance companies do every year. They look at their total dollars and they adjust what benefits are available to fit the budget. So the benefits could expand or shrink depending on what we think of as a feasible financing structure, but we need to know the financing structure first. What do those revenue streams look like, and how much do you anticipate they could raise? And then we can sort of adjust the benefits based on that.
Thanks, Helen, for that great explanation. And we'll go into way more depth on revenue in upcoming meetings today, and hopefully at our next committee meeting, regularly scheduled committee meeting, we'll close the loop on the expenditures, at least the approach. So, and in my haste to insert this extra agenda item, I skipped over several. So sorry about that. So let's move on to the tech check first and then the roll call. Katie, if you can help with that.
Yeah, perfect. Thank you, Cheryl. Just a reminder to everybody on how to use Zoom. I think you're pretty familiar with it now, but just make sure to click the raise hand function if you'd like to speak. And then if you're able, keep your video on, and then stay muted when you aren't talking. Jeff, did you have a question?
Yes, just to follow up to Helen's presentation, the description of where we are. So we now have a target number that we should be able to get as to what are the annual requirements based upon the PED plan that's put together. I think that'll be helpful for us to have at a subsequent meeting, or if it's readily available now, to give us an idea of what the number is we're trying to get to. Thank you.
Thank you, Jeff. That is noted. And from here, we're just going to go ahead and do a quick roll call. So today, as I call your name and you are saying that you are present, if you could just please share with us what your first job was. So think back all those years ago, or maybe not so many years ago, and share that. So we're going to start with Cheryl Ramirez.
I worked in the dietary department of a hospital.
Nice. Thank you, Cheryl. John Santa.
I'm here, and I picked up and delivered specimens for a group of pathologists in the Central Valley of California.
Thank you very much. Richard Gibson.
I'm here. My first job was stringing tennis rackets in Phoenix, Arizona.
Thank you, Richard. Charlie Swanson.
Here, and my first job was a lifeguard or maybe computer programmer. It depends on if you want part-time or full-time.
I love it. Thank you. Jeff Goodman.
First part-time job mowing lawns. First full-time job selling tarps, awnings, and polyethylene film.
Oh, wow. Nice. Chris Hogan.
I'm here, and I was a Safeway bag boy in Coos Bay, Oregon.
Love it. Thank you all so much. And then, of course, we have Bethany Stairs and Sam DuPont, a part of the committee, but they had engagements already today, so we're not able to join us. So with that, I will turn it back to you, Cheryl.
Thank you. So today's agenda is pretty simple. And again, we're going to focus on the discussion of the health spending approaches. So we'll provide a very brief summary on the feedback. And if you've looked at the slides already, you know what that is. I actually don't know what the update on the board policy change is. I apologize. I don't see it anywhere in my notes. So if Morgan or Katie has any information on that, I don't know what it is. We'll be. Oh,
can I just, apologies, that will be on your next meeting agenda and will not be part of the meeting today.
okay, thank you. So like I said, we're going to hear from Janine Smith on health spending, the three approaches anyway, some comparisons, pros and cons. And I'm also hoping that you'll have your own pros and cons, benefits of including a particular approach, and of course questions too. And then we'll reflect. I'm hoping actually that we'll get to a recommendation on the approach today. So I'm going to put one out for a recommendation and see if you all agree, or if you have a suggested revision or a completely different recommendation, certainly open to that. I understand that at this time, there's no public comment. I don't know if that can change over the course of the meeting or not, but there isn't any right now. So, and we'll be spending today 2 hours as opposed to 3. So yeah, really focused. Okay, so of course we got a lot of data requests both in the meeting and after the meeting. You can see that I'd rather not just read over all of the summary feedback. We had talked about identifying the expenditure data from the sustainable cost target growth that was missing. And I think we can do that for any of the 3 sources that we were looking at today. We need to decide whether we stay focused, and this is my recommendation on the PEB benefits. So that'd be mainly clinical services for this first phase of our expenditure approach. And let's see what else. Oh yeah, I think this is down here. Could you move the slide up just slightly? I can't see the end of the bottom, or maybe you can't, I don't know. Okay, yeah, there was some agreement that we stick with the joint task force recommendations. The task force had set aside expenditures in the Department of Corrections, Veterans Affairs, and the Oregon State Hospital for now. Okay, so moving along. I wanted to mention in terms of gathering the data, I don't believe we have a solid approach for collecting self-insured data, so I'm hoping that topic comes up today. We did have some concerns about the timeline to gather all the data because the plan design and the community engagement committees are dependent on our baseline health expenditures data for their work. And so that way, if we look at the data that we actually need or have already, then the ask for staff will be a bit more limited and adhering to our timeline for this committee. My own feedback, I just wanted to throw in there right now before we get started is I really liked the healthcare data methodologies comparison document. It was one of the attachments. And I found the table with the data source columns and check marks and X's indicating whether the particular data source had that data very helpful. And I'm wondering if we could if we could add the cost growth data as another column, just so we could look at it across, that would be really helpful just visually for me. So that's an ask that I have. So now I'm going to hand it over to Dr. Janine Smith, who has joined us before. And as you may remember, Dr. Smith is from Health Management Associates. We'll give her the floor to briefly review the 4 approaches on the table and provide an analysis of key differences. Then I'll ask each committee member to share some pros and cons from your own deep dives into the 4 approaches. So first, by way of introduction, because I don't think we did this last time, Janine Smith is in HMA's Portland, Oregon office, bringing over 20 years of experience serving state and county governments, health plans, health systems, and primary care and behavioral health providers, including rural and tribal clinics, providing expertise to improve health policy and the delivery of healthcare. Her range of experience includes serving under 3 Oregon governors, developing major health policy initiatives for the state's Medicaid and overall health system transformation, while serving as the first chief medical officer of the Oregon Health Authority and administrator of the Office for Oregon Health Policy and Research. Dr. Smith was part of the HMA team that supported Oregon's Joint Task Force on Universal Healthcare and is very familiar with the Universal Health Plan Governance Board. So with that, I'd like to hand it over to Dr. Smith.
Thanks, Cheryl, and hello again. So our goal is to focus in on what we want to use as a base expenditures, and then I'll give a brief overview. I know you've all had the resources to look at. And as Cheryl said, we'll talk about the pros and cons so we can then decide the direction you all are going and what we can start to take the next step into transferable revenue sources and other revenue sources, as Helen presented a minute ago. Next slide. So this is a lot of words, and I'm not going to read it entirely, but it's one of the options, and there's sort of 4 laid out here, is to use the National Health Expenditure Accounts data. This is what the nationally is used to estimate what is paid to providers, as well as multiple other categories of medical goods and services. And it's been around since the 1960s. It tracks personal health expenditures and from payers, as well as non-operating revenues, grants, subsidies, philanthropy, etc. Sources are, there's a lot of them, and they take a lot of it from U.S. Census surveys, the Bureau of Economic Analysis accounts, MEPS, Medicare, Medicaid, etc. The last data set is from 2020 because of its ties to the census, although they look every 5 years at any new data sources that they can put into it. The next review is due in 2025 and to be potentially some revisions, if any. It does require, if you chose to use it, is some staff time to pull out the desired components for Oregon, because it's a national view, and then they pull data sources, look at census data from Oregon, and etc. And I think for some reason the picture is not showing the last bullet, but there is one last bullet on. We need to make sure that there's some detail in the methodology papers. The last methodology paper, I think I gave you the link for that, in 2022, describes each category and how they try to avoid double counting. So the next one is Oregon's own all-payer, all-claims database. I worked in state government when this was first started and helped to work on the bill to get this, and there are about 30 states in the country that have their own all-payer, all-claims database. And it started back in 2009. It's claims paid to providers. There are mandatory reporters. You will notice that the TPAs, third-party administrators, that the self-insured employers would use. It includes those with 5,000 or more covered lives, which is slightly different than the cost growth. I did check with Sarah Bartleman, who's the head of the that knows all things in the analytics department. And she said they have about 31 to 60% of self-insured in the all-payer database. There is a claims lag. They collect data on a rolling schedule. It takes about 15 months to get the full complement of the year into it. The 2022 claims are complete and were available to be requested in 2024 January, and the next set will be ready by January of 2025. You do have to put in data requests. There isn't a workbook quite the same way as the other the next one I'll talk about, but there is you would have to get the data requests and then some turnaround time and have to assess how that data would need to be aggregated. And I think you would think there's also a one more bullet on that slide that there's just have to avoid double counting in your request. I don't know if we can just get rid of that top line, the toolbar, maybe that would help to be able to show the whole slide. The third potential source of a base to choose from is the one I talked a bit about last time, the sustainable cost growth target expenditure data. This is what only about 8 states are able to collect. So it's, you know, again, both the all-payer and this one are Oregon driven, collected, etc. This one is newer, 2019. It has mandatory reporters as well, but you'll notice that it's for any third-party payers for the self-insured with at least 1,000 covered lives, so slightly higher mandatory reporting there than in the APAC, which is only 5,000 lives. It's the allowed amounts, and it's collected annually in September. There are some voluntary reporters as well that don't fit into the main categories, but they and it's variable as to how many they get. But when I asked Sarah again about, they think they get at least 60% of the self-insured lives are represented based on DCBS enrollment reports. Current data is available in the workbook online, was updated most recently in August with the 2021 and 2022 data. They have collected data back to 2018. It also includes investments in behavioral health and the state hospital corrections, VA, Department of Defense, as I showed you last time. They do have a very detailed methodology data manual that outlines how to avoid double counting in terms of those who are on dual coverage of Medicare and Medicaid, etc. And then the fourth one is sort of the option of trying to pull all the data together from multiple sources. That would require the Oregon Educator Board or OEB program, Medicaid, making sure that the Bridge Plan and Healthier Oregon are included, Medicare, or see if what's available online. The commercial plans, you would have to, if you weren't going to use APAC and cost growth, then it would be a separate direct ask to the health plans. And then the third-party administrators. Obviously, the state programs are the easiest to get of all that. The time periods, you'd need to make sure the ask was correlated, so you're getting it all in the same time zone, and it would require significant staffing and time to collect and aggregate those streams. So this is some mixture of this and the NE, National Health Expenditure data is what Optimus did for the task force, but that was before we had the cost growth program in place. And then you need to make sure there's not double counting. So the next slide for me here is just kind of, I tried to lay out the differences. The national health expenditure is collected nationally and then allocated amounts to Oregon. The APAC and cost growth program are collected directly from Oregon payers. The different times and different approaches. And then obviously having to go collect the data directly. The National Health Expenditure data is older, so almost like in the middle of the pandemic, versus we have 2022 data available in the APAC and the cost growth. There is some stuff online, the NHE, I can never say it. National Health Expenditures is online with these giant zip drives that I am incompetent to open, but others who are more numbers crunchers could probably do that. And then you'd need to ask a formal data pull for APAC. The data book is nice on the cost growth program because you can see some detailed lines by Medicare, Medicaid, et cetera. And then versus asking for all this data to come in. I think, and then, you know, some of the more specific Oregon stuff is not in the national one. Some of the specific self-insured data is a little stronger in the cost growth program than it is in the APAC at this point. And I think that's all on this slide. I'm not sure what's at the bottom that I'm not seeing. So with that, I think I'm turning it over to you all to have a discussion.
Hey, Janine, I have a quick question. Is it possible to include in that chart or in the chart I was talking about the percentage of healthcare expenditures included in each of those data sources? Like we've got to, 75% of all the healthcare expenditures in APAC or whatever. And we've got, I don't know, 90% in cost growth. That would be helpful to me too, just to know how close we are to having all of the healthcare expenditures.
Yeah, I think you could, the cost growth one, I think they actually, and the APAC both have those. I'm not sure how to say that for national health expenditures because of the sources that are coming from. There's such a myriad of sources, it's harder to say. I mean, there's estimates of what they think from the national level. I don't know if they have, from what I read, so to date, I haven't seen that there was an estimate that the Oregon data has X percent versus the California data versus the Washington data. It's just in general, the national health expenditures has some percentage, probably closer in the 80s and 90s overall. APAC probably is up there as well as cost growth.
Okay, thanks, Janine. Chris, go ahead.
Thank you. I've focused my comments on the cost growth data. I think that's my preference. I'm familiar with the data, and it seems like Oregon specific data that is has some gaps, but perhaps those gaps could be filled with supplemental data requests that we could bake into those. I do think Helen's comments at the beginning of the presentation changes the ask in my mind. If we're not trying to get to a very precise base period, if we're primarily focused on a financing structure, then maybe we need to be less concerned about getting all of the assumptions really close to accurate. If we can get to something that's 98% there, then perhaps that's good enough to get to that next step. But I like cost growth, and I thought I'd talk about some of its limitations. Obviously, cost growth is primarily data reported by payers. So any medical spending that is not funneled through payers or through the other programs in the other category, those are going to be missing. And even for the reporting payers, certain expenditures are excluded. One that comes to mind is reinsurance premiums net of recoveries. So if this state plan would want a reinsurance policy, then that would be a necessary adjustment. Generally, you spend more in premiums than you get back in recoveries. Loss ratios are usually around 75%. So that would be an added expense that we would need to apply. Certain other expenditures that CCOs especially have include health-related services and social determinants of health expenditures. So to the extent we think this state plan will feature those benefits, then we would want to bake that in. And one of Helen's other comments, modeling this plan probably based on PEB benefits. So I think having that PEB data would be helpful. However, it may be hard to adjust the information we have in the cost growth target data to match PEB benefits because the populations are different. So, we would have to answer difficult questions like if current CCO members had PEB benefits, what would that spending be? And I don't know how to answer that question. The acuity of these populations are totally different. They're just different categories. So that I think is a tough one. Other missing elements, unreimbursed care. So any expenditures that hospitals and clinics just have to eat, that will, following the transition, that will be an expenditure that's not captured in the cost growth data. Self-pay and small payers are also missing elements. That said, I think the cost growth target data states that 97% of Oregonians have some kind of coverage. So perhaps those numbers are fairly small. The last big unknown in my mind is what does administration look like at this universal health plan? Does it look like CCO administration, or does it look more like a commercial plans administration? The two are very different. CCOs, I think, have a lot of administrative functions that most insurance companies don't have. We probably spend more on care coordination and other state policies that other insurers just aren't subject to. But if we use cost growth target, then I think the baseline period is 2022, and I would recommend using total medical expense. And I think in the last presentation material, we were working with a number that was 28 billion. The 2022 TME total was about 29.2 billion. So I think that would be the baseline. We have the trend factor for TME in the 2022 report, 1.5%. And then, in addition to the missing elements I've talked about, we would need to, I think, add back in those elements in the other category that this universal health plan would be responsible for. So that increased behavioral health funding, we would need to bake that back in. Perhaps VA would be outside of the scope of the Oregon health plan. Just my thoughts.
Thanks, Chris. I agree with everything you said. Working on behavioral health and knowing, or advocacy that is, for the system, and knowing that Medicaid benefits are the best, I could certainly see us baking in Medicaid like behavioral health benefits into the plan, and I'm sure you're well familiar with those. Janine, I have an additional question to Chris's in terms of data that's not included in the cost growth target. What about the out-of-pocket payments from individuals? I know we had a presentation, and I'm forgetting exactly if any of those types of costs were included at all.
It's allowable costs, which means what the plan pays as well as what the person is. So if you have a 20% co-insurance or it's all captured in there because it's
Even like high deductible plans, then that would be captured.
my understanding is that the allowable costs got most of it. Trying to think about the deductible, but deductible is just a target. So, but it's the allowable cost. So if you pay to come see me and you have a $25 copay and the visit is whatever, so say 100, you know, the cost that would have been captured in here would have been 125.
Okay, thank you.
And I would just add for Chris, I think he sent a note to Morgan that the non-emergent transportation is included in the Medicare, excuse me, the Medicaid expenditures. So that is captured, which is a unique benefit to the Medicaid population.
Anyone else have thoughts? Whether they're questions for Janine or some information on the deep dive research you did in between meetings? Charlie?
Yeah, I think for Medicaid, we have excellent data with the MBS or the reports that OHA provides to the federal government. And so to me, we might as well use that data because it is probably the best data we have for any kind of expenditures. And it includes all the things that Chris mentioned, everything that Medicaid, all the CCOs spend is included in those reports. So I think it's there. We might as well use it. And I've done an analysis of it and I can do further analysis of it, so.
Yes, thank you for all the work you did, Charlie. I was working on digesting your email in between meetings. That's a lot of work. Thank you. Jeff?
Thank you. And Chris, thank you for your excellent comments. My area to do the deep dive on was the national health expenditure accounts. And going through it, it's the one that it's the most outdated information, which to me is almost an automatic disqualifier. But my question is, of the remaining three, which one will get us the best information? Because I didn't do a deep dive on the other three. And in light of what Helen has told us about going forward, which one of those three will give us the best information about PEB coverage?
Would you like to opine on that, Janine, or give...
Well, I mean, as I said, the APAC is 2022. The next year, 2023, will come out in January. So we won't have it right away, but the cost growth is 2022, and its next update is also due out soon. So, I mean, that is much, so it's past the peak of COVID, which is what the 2020 was concerning in how it's older. The CCOs are reporting directly to the cost growth, and then the cost growth team is getting latest numbers on behavioral health investments and other things from Medicaid directly from the Oregon Health Plan. So they're not having to, so they're bringing in all 16 CCOs data on what they're paying.
So Janine, I guess the question would be to you, if you had to pick one of the four, or in my mind, one of the three, which one would provide us the best information about PEB coverage?
Well, I'd say, I don't think I think the benefits plan is the team is going to look at what's in the PEB, but the PEB data is in here because it's got MODA and the other two options, Kaiser, et cetera, that are PEB plans, that PEB data is in the cost growth.
So that would be the one, if you were forced to pick one.
From a national perspective of having worked with the Peterson Foundation that does cost growth programs across the country, you are a special state that has, as of course I already knew that because I live here, but that has this incredible wealth of information they collect directly from the payers, and it's attributed to providers that only a handful of states have this great of data.
I think that's going to help narrow the discussion substantially, although I'm interested in what everybody else has to say about my line of questioning.
Janine, to your point about the cost growth data, including the PEB data, so can you pull that out so that we do have the total cost of PEB in 2022 if we were to use that for the baseline?
I mean, you could probably pull it out. I mean, you could also ask PEB what they've spent per person. I mean, if you think about it, you're trying to come up with a target for a benefit plan.
Right.
What does it cost per person to cover a PEB person versus cost for if you covered everybody with that? I think you get into some of the issues Chris brought up as the higher acuity in Medicaid. There's different payment rates. So what it costs in PEB right now is based on the commercial rate that's being paid to providers. The cost of covering a patient in Chris's CCO is what based on the cost they pay the CCO to pay their providers. So it's hard to really get that. You know, what this fourth data options are is getting at what was spent. So what was paid out.
Okay, thanks, Janine. I'm going to go with John first and then Charlie. Go ahead, John.
Yeah, I mean, I also looked at cost growth target, and I mean, this is complicated stuff. I think at the highest level of cost growth target, the data may be best, but I don't think that's going to mean we aren't going to have to look at what we think the best data is in Medicaid, and the best data we think in Medicare, and the best data we think in commercial. I mean, let me read you a brief statement that comes right out of the cost growth report. They say, quote, Medicaid trends identified do not necessarily align with CCO global budgets, trends, or the state budget for the Medicaid program due to significant differences in methodology, inclusion, and exclusions, and data sources. I mean, the challenge you have is cost growth target is designed to do comparisons about cost growth. It's not designed to be a source of information for a benefit design. I was surprised, for example, in the discussion of Medicare data in cost growth, they do not include data from traditional Medicare because the CMS report uses a different approach. So, you know, I'm scratching my head going, well, now, when it comes to Medicare, I thought it would be easy, but it doesn't sound like it is easy. And, you know, it's going to be crucial to know about traditional Medicare. It's going to be crucial to know what % of traditional Medicare folks purchase a supplemental plan. It's not 100%. It's not anywhere near 100%, it looks like. And so that's a very significant cost that, you know, someone's going to have to cover. So I was worried even in Medicare. You know, the big hole is commercial. And it looks like cost growth and APAC probably have the best estimates for commercial. And between the two of them, you know, it's not going to be perfect, but in that realm, you know, they're perfect. No, they're not perfect, but they'll be the closest thing we can get. The other aspect I think, you know, we should be aware of is that folks looking at our work are going to do probably what some of us tried to do. And that's, okay, how much money did the federal government send to Oregon for Medicaid and for Medicare? And what happened to it? Where did it go? You know, to me, we have to be able to show that we have some idea what happened to that. And you know, the closest I could come to kind of figuring that out was to look at Charlie's work, which, you know, revealed, well, wait a minute, you would think, you know, these two should match up, but they don't quite. And, you know, you know, even you'd look at, well, how much do they differ? Since you're talking about billions, they're 500 million different. You know, $500 million is a lot of money. And why are those different? What's going on? So, you know, I don't think there's going to be one source that we can say we'll just ask them to do the work for us. To me, we should look at the three categories and look at what's the best source of information, and what other information may some folks see and go, well, explain why this is different. I could see that in Charlie's work. I couldn't understand it all, Charlie. You know, sometimes just because of the acronyms, you know. I think that's where I'm at.
Hey, John, so just so I can reflect what you said and see if I understand it, are you suggesting a hybrid option? So we use the commercial insurance information from the cost growth target. We use, you know, the direct Medicaid, Medicare information from CMS for those two, and maybe something else for another health plan. Is that what you're suggesting?
Yes.
Okay, and I just want to make sure I understand, this is not my field. So Janine, can you actually take information out of the cost growth target just on the commercial insurance plans and use that? I mean, it's not like a bundled package of information, or can you just take?
Well, their data book breaks things down by commercial, Medicare, or Medicaid. So that data is there for your.
So that is a possibility.
For eventually, when you have your modelers can pull the lines from it. Medicare does have Medicare fee for service in it. So in the cost growth and the dual eligible, the Medicare part and the Medicare Advantage part. There may be some, it does not have the Medigap plans in there, as they say in their methodology book, but it does have a fair amount of Medicare in there already. So and it has Medicaid that's what's paid out. Like, as if you're a health plan and giving universal coverage, what did you pay out if you were going to cover those Medicare plans? It doesn't have everywhere every single Medicare dollar goes, like some goes to the schools. I mean, there's a variety of avenues that Medicaid funding goes to, but it has what was spent by the CCOs and by Medicaid fee for service in the cost.
Yeah, Janine, you know, I mean, it's a struggle to understand it all, but you know, when you look at the report, what did they report about Medicare? They basically reported, how did Medicare Advantage groups back up in terms of a cost growth target? That's what they're supposed to do.
Right, because they're trying to get the plans to manage the care better.
But essentially that leaves out 40% of the folks who are in traditional. Maybe I missed something,
Well,
but
it has the traditional A in there for sure. I'm not sure how much traditional B it has in there. So
yeah, well, but I don't think anywhere they said, well, here's how hospitals did with people who only have traditional.
it does it does have in the data book a line Medicare fee for service.
Yes.
And it's part A and or part B is in there. So we can certainly, the team can certainly inquire from the cost growth team exactly what's in and what's out. So.
But don't get me wrong, for our purposes, we're not really interested in going deeper down. We want the top number and the next level down in terms of hospitals, doctors, drugs, etc.
Right, which you're getting there. It's just that you might be a few holes because it wasn't reported in by the mandatory reporters.
Yeah. Okay.
Okay. Go ahead, Charlie.
So I'm going to echo a little bit of what Janine said relating to, I think, Jeff's comment about PEB benefits and trying to use those numbers to estimate what the expenditures might be. I mean, the biggest thing we have to remember is that PEB pays providers really, really well. Medicare and Medicaid do not. And as a task force planned to do, and I expect that the governance board will plan to do, is to sort of equalize payments so that on average providers get about the same amount they were getting before, which means that the new people who are going to be added to having these PEB benefits and the PEB, those who are currently on PEB, the payments would be very different than they are now. So I don't think that's going to be very useful at all, other than just to get total expenditure amounts. I will also push back on the notion that the NHEA data is not very valuable. I would say it's extraordinarily valuable. It gives us a basis for how we can set up our estimates. It is what Optimus used and did a good job with in the task force. It is also, I also push back on the fact that it's old data. I mean, yes, the Oregon data is only through 2020, but the national data goes up to now, essentially, well, up to 2023, and we can impute values from that. I would say that wherever we can find better data than the national expenditure accounts, we use that. But, and for example, as I mentioned before, we have great Medicaid data. There's no reason to use anything other than MBES data for that, for expenditures. And also, we can make use of the national expenditure account and integrate it with the other data. And somebody was saying, oh, we have a lot of staff time to do this. I'm doing a lot of this work already, and I will continue to do a lot of the analysis. So I would push back on the fact that there's going to be a lot of staff time. I mean, we can check what the staff does if they want to do it, but the staff can check what I did. But so another example of the difficulties with the cost growth target, I think there's a lot of useful data in there, but I will mention a few things that are missing. For example, we have really good data on hospital expenditures in Oregon that's put out by OHA. And so I've made use of that. And if you look at that, the net patient revenue amounts that are reported by OHA compared with the cost growth target data, it's only about 10.5 billion expended for hospitals with the cost growth target data, but net patient revenue for that year is like 15 billion. So we know there's a lot missing. One of the great things about NHEA is they make a extraordinarily valiant attempt to include everything. And they make estimates where there's not good data. And so, and they work hard at making good estimates. And so I think that forms a really good baseline, and we make use of better data where we know it exists, and we make use of the comparisons between the data sources. I'll also say that I think another very useful thing that we might be able to get from DCBS is they put out a report of that you can find online of all of the health and accident insurers and their premiums earned and medical expenses paid, or losses actually incurred is what they say. So it's not necessarily all medical expenses. And that data exists. It's you can find it online for 2023, but it's in a really difficult way to use. I'm sure DCBS has that in a spreadsheet somewhere that they could just provide to us. But the way it is, it's in a PDF, and it's really difficult to get that many lines of a, it's like 10-page PDF into a spreadsheet in a reasonable manner. And I'm assuming they've got that same data for 2019 through 2023, so we can look at trends. I'll also say trends are going to be useful for us. So I think we want to do that to the extent we can, and I think we can. And so those are some of my basic comments, and I guess I will stop there.
Thanks, Charlie. Chris.
Yeah, just following up on Charlie, not being familiar with the NHEA data, I think Charlie's right. It could be used, and we know what those trend factors are for the intervening years, and so they could be applied to forecast out whatever year we're looking at. Makes sense.
Thanks, Chris. Richard.
Yes, I was asked to look at APAC data, and I think it's got some great, along with the Costco target, great benefits in that it's exact detailed claims, including all the out-of-pocket, which is really hard to track. It's a lot of money, and it has it there. It also has claims for most, but not all Oregonians. The other nice thing about the APAC data is since it's not summary data like the Costco target is, you have individual claims on individual patients. You can run risk analysis, put them in different clinical risk buckets, and that way you could estimate how a person with certain medical conditions would likely spend. So it's great for applying risk calculators and spending calculators to estimate what kind of population you're picking up. The big downside for both the Costco target and APAC, from my point of view, is that you're getting almost all the fully insured, you're getting all of Medicare, Medicaid, you're getting all of Medicare by and large, but you don't get the uninsured, which is roughly 6% in Oregon, and also you don't get a lot of the self-insured. Based on you're getting about 44% of the self-insured population in Oregon, which is about half of the commercial insurance. So if you're using, no matter whether you use an NHEA or APAC or a Costco target, they all have holes that you need to triangulate into and estimate. So my overall feeling is that I think that we should use the NHEA as the outer parts of our spreadsheet, meaning they have sources down the left-hand column and uses across the top. And if we're going to create, I think we should create a spreadsheet for all healthcare expenditures in Oregon. And I really like the NHEA in its categorization because it's so detailed and it has subcategories, and you can see where every administrative expense goes, where public health goes, where they spend for research, for structures, for equipment. All that is great to have in accounting. Then, as John said, use the best data for each of those commercial, Medicare, Medicaid, uninsured, TRICARE, VA, DOD. Even if some of those aren't in Oregon, that are not going to be part of our plan, use that sources and uses of the NHEA to build our spreadsheet and then go look for the more specific data. Finally, I would say, it's a great way to look at NHEA and say, what did we miss? Because they have such a great categorization of both sources and uses that at points you say, hey, did we account for that? And Charlie's great at picking up, hey, did we account for that? So that's a great thing about using NHEA. It stimulates you to say, why are these two different data sources? Why are they different? And it's not only satisfies your curiosity, but it helps you look at things that you might otherwise miss. So I would say a hybrid approach where you start with the NHEA categorizations and gross numbers and then refine them based on the best available data in each of the markets. Thank you.
Thanks, Richard. I just have a follow-up question. How do we tackle the self-insured data? Do you have any suggestions, or do any of you? I mean, because that, in my mind, that seems to be the biggest gap at the moment. Correct me if I'm wrong. Go ahead, Richard. Did you have?
Yeah, I have a couple of ways in. Number one is we can compare it to what NHEA estimates for that. Number two is that we can extrapolate from commercial insurance, both fully insured and commercial insurance that's self-insured for those that we do have claims in all payer claims database or in the cost growth target, and then extrapolate to the rest of the self-insured. I mean, we know all the companies and that are doing self-insured, although we don't have their claims because they're not mandatory. So I think extrapolation will get us pretty close based on they covering relatively similar employee populations.
Thank you. Charlie.
I'm going to echo Richard. I think that we can fill in quite a bit of the self-insured by using a combination of the NHEA data, which makes the attempt to estimate what the self-insured are doing, and also using the both the cost growth target data and the APAC data to fill in and see how can, it doesn't make sense. Do these numbers make sense? So in many ways, the most important data is going to be what do private insurers pay and what is paid out of pocket, because that's the money that we essentially need to raise to cover things in Oregon. Depending upon how much we save because of an administrative simplification or whatever else, but roughly it's going to be about the amount that is paid by commercial insurers and out of pocket. And I will continue to look at the cost growth data. The data book has lots of detail. The cost growth target data book has lots of detail in it, and that can be used as long as we try to make an estimate of what's missing. I will point out another thing that's curious to me, and Janine might be able to help answer this question, and that is, so CMS puts out Medicare expenditures in traditional Medicare. I mean, that data is among the best data available for researchers to use, and so they put out what are the expenditures in each state, and the expenditures in Oregon for traditional Medicare appear a lot smaller than what the cost growth target says was spent in Oregon by traditional Medicare. And I'm wondering if the cost growth target traditional Medicare category includes the amount that was paid by those people out of pocket and also the amount that was paid by Medigap policies in the Medicare, traditional Medicare category, because otherwise it's hard to explain why that number is so much higher than what CMS says was spent.
And I'm not 100% sure, but I'm sure the cost growth team could get specific about how I think they're collecting it. Obviously, their mandatory reporters are the plans that are offering the MAs. They're bringing in data just like they do in APAC from Medicare reports. So I just don't know what they're bringing in versus what they're unable to bring in to do both the databases.
And
Okay.
Medigap is excluded.
Yeah, and Medigap is specifically excluded because it was just
in the traditional Medicare numbers. So when they get data
they have Medicare, they call it Medicare fee for service in the data book.
Right.
And they have specifics in their manual over what, obviously the mandatory reporters are the plans and not, they don't ask the federal government to be a mandatory reporter. So they they do have access to Medicare cost reports.
Okay.
Don?
Yeah, I mean, I suspect that there's a subset of consultants and actuaries that are very focused on serving self-insured employers or serving employers who are interested in the pros and cons of being self-insured. And, you know, my guess is I would hope that Optimus, to some degree, was either in touch with those folks or, you know, does some of that business, and they were able to use what they've learned to make the estimates they must have used for the task force. When I was at PEB, we used Aon, you know, a national consulting firm. And in those days, we were starting to look at the self-insured choice. And, you know, it would probably cost some money to have some of those folks come in and look at APAC and cost growth and the experiences they've had and the information they have access to, and give us a sense of what would be an appropriate multiplier for the you know, self-insured business that isn't reported in those places. So it's just going to be a matter of having a credible estimate. It's not going to be perfect. So, but those folks are certainly out there.
And I'm sorry, thank you, John, and I'm sorry to put Morgan on the spot, but is this something that we could contract with Optimus or some other consultant to do for us, or is that not viable?
Well, right now, the plan is to absolutely bring in an actuary to help work with the plan design. You know, what we're doing right now is a step and an exercise to really get to the heart of this committee, and that's to try and come up with that revenue plan. As Helen was saying, you know, looking at what are the taxation options. But an important part of this is to really understand who's paying now. So you would be able to talk about how people would pay under a universal health plan system. So we have the actuary, a kind of an RFP plan for an actuary, and we're going to bring in some additional support for this committee for the revenue piece, because while we're have been working with the Legislative Revenue Office, as the legislative session gets started, their attention will really focus on the legislative session, and we might not have as much access to them. So we haven't been talking about bringing somebody in for this part of the exercise, but really focusing on that revenue piece. And to the extent that there is lots of data out there that's available, that wasn't part of the plan.
Okay.
And what I'm learning from state government is all of that, those processes take a little bit longer than
that's kind of what I
that they would take.
That's kind of what I was thinking, but I thought I'd ask. Go ahead, Richard.
One of the areas that we'll need to look at, regardless of the overall approach we take, is in double counting. If one looks at the numbers from DCBS for commercial, both fully insured and self-insured, Medicare, Medicaid, and uninsured, you come up with a number about 4.7 million. And we know we have 4.2 million people in the state. So there's a degree of double counting going on there somewhere. And we know where that could be. It could be with self-insured versus self-insured but stop loss only. There's probably overlap there. There's Medicaid fee-for-service, and I mean Medicare fee-for-service and Medicare supplemental. There's there may be overlap and double counting there. There's self-insured that may be getting some benefit from their spouse's policy, and they talk about that in the self-insured part. So there's maybe double counting there. There's dual eligibles, which is well accounted for, but it can confuse the data. There's the overlap of accident insurance, and the overlap of student insurance. So there's lots of places for double counting where the numbers don't work out so well. So that's why we need to be curious, start with the NHE framework, and then dig down and maybe use our consultants to clear up some of the inconsistencies in the numbers. Thank you.
Okay, thanks, Richard, for bringing that up. I was wondering myself how we guard against double counting because it came up under every single option. So don't want to do that. Want to have credible data. Chris, go ahead.
And just continuing, some of the line of thinking we're on. I do think we could spend a lot of time, getting really close to what is current spend. But then, knowing that the target benefit structure is similar to PEB, I don't know how we make that conversion accurately. It seems like, whatever status quo number we might come up with is going to be far off of what expected spending would be. And so I wonder, how close does this group think we need to get to that next step? Thinking about some of Helen's comments from the beginning of the meeting, if the aim is just to get to some very rough number that we can apply our model financing structure to, then maybe that's enough. And the plan design group can bother themselves with the details of utilization and unit cost and all of those details. I don't know, what do people think?
Yeah, that is a central question. I'd like to know myself, what's good enough? And as you said, our main goal here is to come up with a revenue plan. So we do need to move off of this fairly soon. And so we've got to close the loop fairly soon. So super good question that I'm not sure I have the answer to. Richard, go ahead.
Well, I'll take a stab at the answer to that, is that I think that the two ways are consistent. And here's what I mean by that. So you take the NHE framework and with all the subcategories and you fill it all out using the best available data so that we know right now in Oregon who's spending the money and where that money's coming in from. Then you take the PEB benefits and multiply that times all the people in Oregon. And then you just dial in, as Charlie already mentioned, you just dial in the payment rate for the PEB benefits until you get a correspondence between the NHEA accounting with more exact data and the PEB benefits applied to everybody. Because as Charlie said, it's the PEB payment rate will not apply when you're doing all of Oregon. The payment rate that's going to be applying to all Oregon will be somewhere between Medicare rate and PEB rate. Because it's covering, because to hold providers whole, you're going to pay them less for commercial equivalent, less for commercial, and way more for Medicaid, and some more for Medicare. So I think they're both they can be correlated with each other. You look at but the main thing is you should be sure you know where all the money's going, because once we say we're going to insure all of you 4.2 million Oregonians, you don't want to get out there and say, oh, we forgot that somebody was paying this extra $2 billion over there. And that gets to the last part. I think if we're within 1 or 2 billion on 56 billion of 2026 dollars, I think that we can go on. I also don't think that this is a closed book on December 31st. We do the best we can, and at the same time, we start building the revenue model, and we continue to refine the uses model, and we refine them both over the next few months. So I don't see a problem rationalizing this. And Charlie's done a bunch of this work already, and if we bring in an outside consultant, it will be in focused areas. So I think we've got a good handle on this. Over.
Okay, well, I'm glad to hear that optimism. Charlie, go ahead.
You're on mute.
Thank you. I would say we can also make use of the work the task force did. So after saying, oh yeah, we got to cover everybody in Oregon, they looked at optimists essentially looked at well, how much more are we going to have to spend because more people are covered and they're covered better, and so they're going to get more benefits. But then also they looked at, well, how much are you going to save primarily because of administrative savings, and the end result was that we're going to spend about the same amount. And I think that we can take that and say, okay, that's our first target. We're going to spend about the same amount. And so what do we need to tax for? We need to tax for the amount that is spent in commercial insurance and out of pocket. And so we make an estimate of those, and that gives us a target amount for what we need to get revenue for. And that I think is our starting point. And I think we can get close enough to that fairly quickly.
Okay, thanks, Charlie. John?
Yeah, I mean, just a reminder, the task force chose PEB benefits. Optimus dealt with that. I do remember them coming back and saying, now, realize Medicaid has better benefits for children or better benefits for hearing. And so they made adjustments and tweaks as they went along. Then I wouldn't be doing Optimus justice and the actuary we worked with if at this point I urge everybody, I think it's either table 7 or 8, where the actuary would always emphasize to us, look at what happens when reimbursement is normalized and billions of dollars switch out of commercial into Medicare and Medicaid, because the payment factor is going from 85 in Medicaid and 100 in Medicare to an overall payment factor of 123, because we're paying commercial, as has been mentioned before, at 170 now. And that shift in resources is enormous. It's huge. So that actuarial model will do all of those things.
But talk about equity in Oregon, that's it. I mean, in my mind, that's the greatest source of inequity in healthcare in Oregon, is that people, because of race and background and income, are not getting the same healthcare. And what we're doing with the Universal Health Plan is the greatest single tool to equalize or to remove inequity in healthcare in Oregon, in my opinion.
I can't agree more. Thanks, Richard. Charlie?
Yeah, one other quick comment. I think regarding base year, I think we are, I'm going to channel Warren George at this point. I think we should use as a base year either 2022 or 2023, because we can actually get real numbers for that, and also model from real numbers for our tax plan. And then at some later time, we can extend forward and see what we think happens. But I think at this point, we're better off sticking with both the expenditure and the financing and the tax structure with a base year of a year that we can actually look at and get data for. So thanks.
Do you all agree with 22 or 23 as a base year? Maybe we could start there.
Well, and when you say use 2022 or 23 as a base year, you would prefer to take the NHEA data and project that forward into 2020. Okay, I see what you're saying. Makes sense to me.
Rather than using just the framework as Richard said, and plugging in the cost growth actual 2022 data. So you're going to use extrapolation from a 2020 census and beyond, who knows when, data versus using your own captured data for 2022 that you already have, though it may have some missing gaps?
To the extent we can figure out what those missing gaps are and make decent estimates, we'll use that. But we need to, if we can make those estimates, absolutely. If we can get better data by making use of the cost growth target data, then I think we make use of it. But we need to check on that and see, can we actually fill in those gaps and make reasonable estimates? And that's an open question, I think, at this point, but it's something I'm going to try to do. We'll see.
Okay, so let me just tell you what I think I hear, and you tell me if I'm wrong. So what I'm hearing is, I don't know if we have consensus, but I'm hearing from all five of you, or there, yeah, 5 of you here, that you want a hybrid approach using NHEA data as the framework, and then plugging in the best data from the other sources. So for example, cost growth target has the best data, I think, for commercial insurance is what I heard. No? Okay.
It
Maybe I
may
won't
have
make any
good-
examples,
oh,
but yeah,
yeah.
go ahead.
Well, it has good data for cost growth, but we know, I mean, for commercial, we know it's missing something. And so we need to figure out, can we estimate what's missing in a reasonable way? And I think a combination of APAC and cost growth target and NHEA, we can do a pretty good job at figuring that out. So
Now, will this kind of mixing of sources of data cause us to double count or put us at risk of double counting more than if we would just use one source of data?
no, it's a double check, not a double count.
Okay. So I was going to suggest as a recommendation that we use cost growth data with supplemental information, but it sounds like what I'm hearing, it's, as I mentioned, it's the NHEA data as the framework, and then we plug in the best data source for each of those categories. Do you all agree with that approach? I don't know if we need to do an actual vote or not. This would,
Is to 5?
what was that?
Jeff's got his hand up.
I think it's to be more accurate, I think what I was hearing is the NHEA framework.
Mhm.
Fill in the most accurate or up to date, close to 2022 data we can in their categories, and look to the NHA and others to fill in the gaps. Is that accurate?
Yeah, I would say, Janine, start with the sources and uses categorization by NHEA. And even start with their numbers, but for every number, say, do we have a better number in Oregon? For Medicaid, yes. For Medicare, yes. For commercial, from APAC or Costco card, maybe yes. So, but
You're looking at side by side. Here's what NHA says for that category. Here's what Oregon has in its data for that category.
and if there's something that's wildly different, then we call on Charlie or somebody else to say, hey, let's dig in and find out why they're different. And then we call the expert involved in that and say, can you give us some insight about why we're missing $5 billion between hospitalization from OHA versus hospitalization from the hospital reporting database? Yeah.
Okay. Morgan.
I have a sense of what you're planning now. I guess I'm still a little confused about how the determination for best data is determined. So you see that there's a difference between 2 different data sources, and then how do you decide what might be the best data?
You can answer that question because I don't know.
If I can, let me give you an
Go
example.
ahead, John.
Yeah, let me try this because maybe it's simpler. So NHEA has an estimate for Medicare. Cost growth has an estimate for Medicare. But we know cost growth doesn't include Medicare supplements. Maybe cost growth doesn't include the duals.
It does.
Well, but there's a split, isn't it? Isn't there a
Well,
split?
the Medicare part is put in Medicare, the Medicaid part is put in Medicaid.
Right. So you look at the two and try and resolve, have you figured out why they're different? And you know, include the one that you believe is more accurate. I mean, for myself, I would be uncomfortable with an estimate for Medicare expenses that didn't include the cost of supplemental insurance.
Yeah, that makes sense to me. Jeff?
Thank you. There's no question about the complexity here, and it's really easy to go down the rabbit hole, and we have on a couple of occasions.
Yeah.
But I think what we're trying to get at is the best possible information that's verifiable, do the comparisons, apply it on take that for the PEB coverage, multiply it by 4.2 or however many million people we have in Oregon. That gives us the number. Then our next step is to say, what are the revenue sources, federal exemptions, state exemptions, dollars going in on the commercial side, on the private side, to get us to what a potential net is. I acknowledge I'm kind of the new person coming into this, and I don't have years of experience dealing on the medical side, but I've got experience on the business side. And I don't want to make it more complex than it is. We get a expenditure target, we identify the sources of revenue, and give a report, and acknowledging all the complexity.
Yeah, right. There'll have to be lots of footnotes.
Oh, no question.
Okay, Charlie, and then I'll go with Richard, and then I do want to ask our consultant what she thinks of this hybrid plan first.
Okay, so I also think that I do have a request from DCBS that I expect would be very easy to do, and that is, and I sort of mentioned it already, and that is there is a list, and I can send this to somebody, of like a 10-page PDF of 2023 Oregon market share and loss ratios, line of business, accident and health. And I assume it exists in a spreadsheet. And if we could get that spreadsheet, that would help us, I think. I'm not sure if it would, but I think it would help identify commercial payers. And I think that it would that data probably exists for previous years as well. And so it'd be wonderful if we could get like at least 2019 through 2023 of that. And I expect it would just be a matter of there's somebody in DCBS who knows where that is and just send it to us. And so that would be wonderful if we could get that. I also
would just caution that is already in the cost growth data because they get the enrollment numbers. So then that's where you run into double counting because
no, I'm not counting it in addition to cost. I'm not counting it in addition to cost growth. I'm counting it as a check on cost growth, as a check on everything. It's double checking, not double counting. And I think that's what we need to be careful of. We don't want to misconstrue. We're not adding all of these things together. We are looking at each one of them, what each one says, and saying, does that make sense? And going back to Jeff's comment, I think I didn't quite understand. Maybe I misunderstood him, but it sounded like he was thinking, oh, you do PEB benefits, how much that costs per person to multiply by the number of people. But as John mentioned, and others have mentioned, and I mentioned, and many people have mentioned, we're going to pay lots of very much smaller rates than what PEB pays, because we're going to equalize the payments between commercial, Medicaid, and Medicare. And so that is not really a useful way to think about it, I don't think. But maybe I'm misunderstanding what Jeff was saying. So
it may be a misunderstanding on my part. Where I'm coming from on this is to try and say, here are the PEB benefits. It's coverage applied to each and every Oregonian. What is our best estimate of a PEB benefit per person? Acknowledging all of the points that the very good points that you've made about differences, et cetera, et cetera.
Yeah.
We're just trying to get to a total number.
Yeah. And I think that's what Optimus essentially did. And so I think that we can make use of the Optimus notion of the expenditures are going to be about the same as what they currently are.
You could just extrapolate your Optimus number and call it good and forget all this. Just
well, I think that's one of the things I'm going to try to do.
Optimus inflate it to 2022.
Yeah.
That's our total target. And now let's figure out what's transferable for data sources, which you've already figured out from Optimus as well.
And
Yeah,
it-
I mean,
on the-
that's gonna be pretty much it. I think that'll work pretty well, but we also want to do the other checking, and I'm gonna do it, so might as well make
Okay.
use of it. So,
And on that, just to, if the number's been tossed out of 58 billion, you got 4.2 million Oregonians, that's about $14,000 per person. Is that a number we're comfortable with? If it is, let's go with it.
Well, that would make our lives easier.
Jeff,
I
Jeff,
mean, that was a 2026 number. It was 56 or 55 billion for 2026, and I think we want to go back to 2023 or 2022.
Okay.
But that is among the things that we'll do. So we'll do it.
Okay, so
Yeah, Jeff.
Richard, and then I want to check in with Janine, and I also want to check in with Morgan in terms of next steps if we were to go this route, so.
Jeff, I think I can bridge you on the PEB. I think the PEB is a great way. You apply it to 4.2 million Oregonians. The difference is cost equals utilization times price. PEB will show you what the utilization will be if you take the PEB assumptions about services and you apply that to the Oregonians. It'll tell you the utilization or the total number of services. Then you apply the price factor, and as Charlie just said, it's going to be less than the current price PEB price factor, but that'll get you your total cost. You just dial it down, and
Yep.
it's a check. The other thing is, no matter what way we're doing it, there's going to be extrapolation and interpolation. None of the sources have it all. Optimus doesn't have it, NHA doesn't have it, Medicare doesn't have it all, except in Medicare, perhaps.
Yep.
And commercial doesn't have it all, APAC doesn't have. So there's going to be extrapolation, interpolation. So we just use our ability to, it's like triangulating a distance by doing it from two different points of view. You try to get to the same point and then you understand it. So we use these different sources of data to do a check on the other one and say, is this reasonable? And once it gets down in the range of 1 or 2 billion, we call it good. So we're not going to go down any rabbit holes. We can do this.
I agree. The goal is we are going to be vaguely right rather than precisely wrong.
I'm not gonna cop to vaguely, but I'm with.
That is a quote from the.
Because we're going to have the same set of challenges.
Yeah, but it's going to be
That
defensible.
number about what we're going to need for whether it's income tax, whether it's sales tax, whether it's a consumption tax.
Yeah.
We're going to have that same range of dollar problem trying to get there. So I'm just trying to, I mean, I think we want to avoid a level of precision that will not help us in where we're trying to go.
Right, I agree with that. So Janine, if I could put you on the spot, what's your take on this hybrid recommendation? And then I really want to go into how will we do this? You know, how will this work happen? Because I don't know that I'm tracking that. Janine?
Well, I guess I lean more, I mean, certainly the NHEI framework is a nice way to get at everything that's spent on everything under the sun. But I think we're thinking about a health plan that you're going to be administering. What's it going to cost per person to do it? And so I think trying to get to some expenditures and then you have to, there's still work ahead to think about your administrative cost to that expenditure, and then which of the revenue sources that feed the current expenditures are going to be available in the future for this model. So I think trying to get to something quicker and easier, if you want to double check it all the different ways, it could take a long time. And so I just think that I think from looking at this and having worked with Rand back when Rand was doing the numbers for Oregon, and having worked with seen the Optimists, what they did, I think for me, the cost growth data is the most robust at this point that you can build up from. And so I think you just need to, if you want to double check it against everything else, I guess you can, but that's a lot of work, and I don't know who's going to do that. Particularly, and is that what you want to have happen, and how do you want to getting to Cheryl's, like, you know, it's just, you need to get a ballpark number and move on to the rest of the work. You have a whole lot on your plate to do in a very short period of time, because the number's going to get refined when you bring on the modelers, and they'll do some honing in on it and making it more specific to make everybody feel comfortable going forward.
Okay, Chris?
Janine just covered it. You know, it
Okay.
seems like there will be back and forth. We'll produce some number, and if the plan design folks say it's insufficient to provide the level of coverage they want, then they'll probably kick it back to us and we can
Yes.
figure out which variable needs to be tweaked. So
Yes.
I'm less concerned about getting super close as long as we're, you know, really roughly there.
So I want to ask a question on the process really quick for Morgan. Whatever we come up with today, and I'm not like crystal clear on the recommendation, does that go to the board or do we move forward if we have consensus on this approach?
Two things. I think that the board is going to be asking for straw proposals, and your straw proposal is your cost target, this amount, and a revenue plan to get there. So that would be kind of the overall proposal that would go to the board. I think that it's really important for the board to stay updated on the approach the committee is using, and kind of sticking to that preliminary structure. So if the committee would start to consider options that weren't included in that preliminary structure, I think that that would be a good thing to keep the board in line with or updated on. And the board will be having a meeting next week. So this will be a good opportunity to share the approach and any timeline adjustments that might be needed with pulling this together. Because I think, you know, we'll need to bring this back with additional data for the committee. So there's still future next steps to get to this piece. And we'll probably, I think one of the committee members mentioned this, we'll probably need to start running parallel tracks while we continue to have this conversation. We will still be inviting the Legislative Revenue Office to the next meeting to talk about what are the taxation approaches that the committee wants to start exploring, and, you know, start kind of looking at doing multiple of the committee's deliverables at the same time, or tasks at the same time to meet those deliverables.
Okay, thanks, Morgan. So I'm just trying to figure out how this assignment will be completed. And so do you see committee members, and this isn't necessarily for Morgan, but it seems as though some of you have been working on this. And is it, you know, I'm just trying to envision this, this framework with all of these columns and lines, and then plugging in the data from the best sources, and as you said, double checking. But do we come up with some quicker estimate for the time being? Like you were talking about using the Optimus number and projecting it into the future while you're working on this project, so we can move to revenue? Or, I mean, I'm just trying to figure out the order of things and who's going to do this, and whether there will be it seems like there will be some staff involvement, but I'm just trying to figure out roles here on who's doing what. So if you can help me with that, Jeff.
Oh, my comment is on a subsequent meeting. We've talked about the expenditure side in total, potential revenue sources. We're also going to have to, as a future agenda item, address reserves, because we cannot count on going forward just having revenues equals expenses on a regular basis. We should be making a recommendation as to what level of reserve and how do we get there.
And I know that's in an upcoming meeting. I think it's even on the timeline if I haven't forgotten that. Okay, Charlie.
So I will do a quick estimate from Optimus about the sort of a rough figure of the amount of money that we think we might need to raise in taxes. And I mean, they are already, they have data for 2019 and they have data for 2026. And I'm going to see, make a interpolation essentially. And I'll document how I make that so that everybody can see it, for the expenditures that we, or the money that we think we need to raise based upon the work that Optimus did. And then I will start working on other ways of getting at a number, and that may or may not be done by next week. I'll see. We'll see how it goes. But the quick Optimus thing, the interpolation, I can probably do pretty quickly. So we'll see how that goes, and I will send that to people and document how I do it. Related to, I still have an outstanding question that I'm hoping I can get an answer to. Can we ask for the spreadsheet data that I have mentioned again? As something, again, if DCBS has to do work to get it, then yeah, I don't want to do it, but I'm expecting that somebody just has that and we just need it. I mean, it may or may not be useful. I think it will be useful. Let's put it that way. And so it would be simple if somebody has it, they could just send it to me.
Yeah, I don't know. Morgan, do you happen to know the answer to that question?
Well, I don't have that information. This would be something that we would need to request from DCBS. So I can.
That's what I want to do.
I can make that. Can you please not interrupt me? I will finish the sentence. I will make that request. And I don't have any sense of the timeline for how long that would take, or if that's something that we can get. But I can make that.
Okay. So we don't need to vote on that request. Is that right?
Yeah, I don't think so. Not at the committee level. Is that right, Morgan?
I think when we were having the conversation last committee meeting about wanting to make sure there was a overall agreement on what data, we really needed to have this conversation that we're having today, so that we weren't kind of like, for lack of a better expression, like playing whack-a-mole with just like, oh, let's go out and get lots of data. I think we wanted to have a better sense of the overall approach that the committee wanted to take, and how information would be used together. And so I'm hearing that there's kind of some general agreement and a volunteer to help start pulling that together. And just Cheryl, to answer your other question, I think Cheryl and I will have some opportunity to debrief after this meeting and think about the staff resources that we have, and what we can do. And we do have a meeting next week, and the agenda for that meeting needs to go out tomorrow morning, because we've been really trying to get out agendas a week in advance. So I do want to make sure that we spend a little bit of time today to talk about what we can plan for that meeting.
So we'll wrap this up in just a few minutes, and we still don't have public comment. Is that right, Morgan? Okay. John?
Yeah, I mean, I just heard the word reserves come up. And I'll ask, did anybody see the word reserves at NHEA or at cost growth target or on any other database? Did any of the stuff we looked at this week explain why Care Oregon's reserves went from $700 million to $1.3 billion over the COVID pandemic? Is reserves a cost, or what's going on? I did find it very interesting to read the details in cost growth, because I knew there were drug rebates. I didn't know that there were MLR rebates. I'm not quite sure what those are, but that's interesting. And then there's now rebates that are on the medical side because of Part B coverage in Medicare. One of the challenges we have is these are organizations that and to some degree it's due diligence, are going to try to protect themselves in a variety of ways. Having been in those companies, on due diligence on our side is we need to really understand how this works. And boy, reserves are at the top of my list. if we're going to need to have taxes to raise, you know, billions in reserves, then the insurance industry needs to explain, you know, what's going to happen to their billions of dollars in reserves, and
Yeah, good.
where exactly has that been appearing in their spreadsheets and their balance sheets.
Mhm.
So,
Yeah, it's definitely on the agenda for one of our upcoming meetings, so that's an important topic. Richard?
Yeah, reserves come from an admin expense, and that's in the NHEA, and that's why you've got 20% margin, including labor and admin expense. So it's in there, and yes, we'll have to rebuild it, and that'll be part of our admin expense. In terms of revenue, we're ready to get going on revenue. It's not a signed and delivered on expense. We keep refining the uses, and now we're going to go to the sources, and we're going to build them in parallel, and gradually we get finer and finer, and they'll meet when we're ready to deliver our report. So time for revenue.
Okay, Richard, well, that's a good segue into the agenda for our next meeting next week. So, what we've got as a draft so far is, oh, maybe this is on a slide, I'm not sure, is it or not? We're going to start talking about sources that can be transitioned to a universal health plan, and we're going to start discussing revenue approaches. It seems to me that we need to make room on the agenda to talk about, or to, I guess, do, I don't know, maybe Charlie can give us a straw proposal on what that quick estimate looks like from Optimus. I don't know if you could do that in a week, but yeah, okay. Is there anything else that we need to cover in terms of expenditures? I'm not clear like on how much time the revenue approaches would take, Morgan. Like, I'm sure there's a presentation, and do you have a sense of what that would look like?
Legislative Revenue Office has said that they will be able to give a presentation. What I've been talking with them about is kind of taking a step back. You've already heard, you know, what the task force looked at, but to make sure if there are other options you'd like to start considering or put in the mix, that there's kind of a general, here are different revenue approaches. Here's how much, well, not how much, that would be later, but you know, just looking at the options to start kind of like with most options, not the fewest options. So I was thinking that that would be probably 45 minutes to an hour to allow for enough discussion from the committee and questions from the Legislative Revenue Office.
And do you suppose we should just remind the committee, and maybe we can send this out in advance, of the recommendations from the task force, just to remind all of us where we landed or ended anyway? We didn't quite.
Yeah, and there was a presentation at the first meeting that the Legislative Revenue Office gave on, remember, they didn't land on any recommendations.
Yeah, that's right.
They did have kind of two revenue sources they were primarily looking at. And that was in that presentation. And also just a quick reminder that the Chris Alanak, the director of the Legislative Revenue Office, did give a kind of Taxation 101 presentation to the governance board in during the October meeting. So the presentation next week will not be just kind of like how taxes work in Oregon, but we'll be more specific about what are options to start looking at. And I'd be interested if there are specifics that folks would want to hear about.
Okay. Charlie?
Could we get some time at that meeting to also talk about, I guess, principles or underlying notions we have about how the taxes should look, just so we can have some discussion related to that, and not just how much, but a little bit more into more detailed characteristics, and also why some particular taxes are useful to have in there.
You just reminded me that we still needed to go over our principle and
Yes.
what was it called? Attributes. So that reminded me that we didn't quite land on that in the last committee meeting. So we probably better add that.
Yeah.
Thank you. Richard?
I'd like to commend Morgan and Cheryl and Janine for allowing so much discussion today. I think we had a lot of participation from committee. I think it's really great. And what I would say about next week's presentation, send it out ahead of time, let us study it. And then instead of taking an hour for someone just talking at us, assume we've read it, go back, read the tax report, the tax presentation, read the presentation they're going to give to us, and then start with the discussion next week. Because there's going to be a lot of questions. We don't need someone talking at us for 60 minutes. That'd be fun, but not necessary. We needed to go have a back and forth with them. Assume that we pre-read it and we're ready to discuss. That'd be my suggestion.
Okay. Noted. John?
Yeah, I would just love to have a discussion at the next meeting or a future meeting about, what I would call crudely revenue transfers. So what happens when there's a single payer and there's no reason for PEB any longer? And the state is raising $300–400 million a year for PEB. What's going to happen with those tax dollars? What's going to happen with the tax dollars in OEB in school districts that I know in my school district, it comes across as a property tax. A single payer would result in enormous refunds, if you will, of taxes to the public. Or those taxes would be in some way transferred to the single payer. Any analysis we do, in all fairness, should recognize that, and we should talk about it, which we never did at the task force.
Yeah, I don't remember having that discussion. That's a really good point.
The other transfer is, healthcare companies are 20% of the economy, and maybe they're 15–20% of the employees. Well, now all of those folks' healthcare benefits are going to come through a single payer. And so the costs of the hospitals and doctor groups and various other folks should drop significantly. That reduction in, if you will, administrative costs should be figured into the analysis. So there's going to be some huge trade-offs. I hear that will have a big impact on the amount of taxes to be raised. So I just want to bring that up. Thanks.
Yeah, that's important. And I seem to recall that we were pretty conservative on administrative cost savings with the task force. So probably didn't include all of those things that you're mentioning. Okay, with that, I think that's probably enough for the agenda. Next week, Morgan and I will kind of look through it and assign times, and then obviously we're going to assign homework for you all if you don't want a presentation. So be ready. Anything else for the good of the order? Okay, I'm going to adjourn this committee meeting. Thank you all for
Great job. Thank you all.
good
Yeah,
discussion.
thanks everyone.
Okay.
Be well.
You too. Bye-bye, everybody.